It's growing
Sure.
organically. It has no company that
Sure.
pushes it. No one makes money out of it, which is always a difficult thing because if you make money out
Yeah.
of it, companies push it. It grows like crazy. You make an
If there
industry
was
out
a
of it.
product involved, right? If there
If
was
there
a
was a
product
product
involved
involved,
to the magic, it would be exploding.
it's exploding. But the crazy thing is that it's every conference you go to, and I think you will attest to that. Every conference you go through, it's now there. There's either a full
Mhm.
lecture on it or somebody's lecturing and they talk about it. Oh, and this is a socket shield case or a root submergence case that I did. It's out there and it's growing, and it's growing because it works biologically and
Mhm.
because it's free.
And yeah. And 3, 2, 1, and we are back with Coffee Break with Coachman, where I'm usually here with my dear friend Kirk Barrett, interviewing, chatting with some of the most interesting people in the dental business. And I know that every time I introduce the expert or my guest, we say top guy, etc., blah blah blah. Very excited about having XYZ here. But today I'm genuinely very, very excited to have one of my best friends in the dental world. One of my best friends on the lecturing circuit. We meet each other usually in different countries. This year already, I don't know, 3, 4 times, from Asia, Africa, Europe, South America, North America. We are always connecting. And every time I'm going to a conference and I see his name on the program, I'm like, oh, that's cool. Makes my trip nicer. I know I'm going to have at least some nice drinks or a dinner and have some great conversation. So, Howie, thank you so much for joining us from South Africa in between your patients and your traveling. It's an honor and a pleasure to have you here with us.
Thank you, Christian and Kirk. It's a real pleasure. I couldn't comment more about what you say. It's always a pleasure. It's always a pleasure to sit and chat. And I think the best part about it is that our chats usually are not about dentistry. Our chats often are about life, and I think that's one of the coolest things. Often we get stuck. We get stuck in our mindset of life. Or on dentistry, and especially when we're at these things, we're like little gerbils talking to each other about dentistry, and I think that's the coolest part. There are very few people that you connect with where it's deeper. There's a connection. That's the cool part. So thank you for having me. It's an absolute pleasure.
But today we're going to do something very, very different. We're actually going to talk about dentistry. As you said, we never do that, but today we're going to be very practical, pragmatic, and straight to the point about your main topic when you lecture: partial extraction therapy. And actually, this episode we are recording with you, it's part of a series of episodes that we're going to start doing that are very technical, clinical, practical interviews. Usually, me, Kirk, we usually like to talk more about the conceptual side of the business of dentistry, management, people, relationship, communication, marketing, all these topics beyond clinical that we love talking about. But I think we need to blend, and I want to go back into technical issues. And I know that our audience wants to also leverage our expertise and our capacity of summarizing and really filtering all these topics and bringing them in a very simple way for people to understand new possibilities, new techniques, new technologies, and know what to do next if they want to learn more. So, partial extraction therapy is something that made you really internationally known. You have many publications and you took this topic to the highest level possible. So, first of all, explain to us, what is partial extraction therapy?
All right, so we'll talk about why we got to it a little bit later, but it's essentially
Yeah.
partial extraction therapy is any technique, it's an umbrella term that covers any technique where you are not extracting the full tooth and you are leaving some of the tooth behind. And the purpose of leaving some of that tooth behind is to maintain the buccal plate, to maintain the bundle bone, the periodontal ligament, and to prevent ridge collapse. Because I think that is the single biggest crisis that we have in dentistry, that ridge collapse. And I think it's one of the reasons why we have such high levels of peri-implantitis and such high complication rates. So that is basically, in a nutshell, what it's about.
Yeah. So you have a tooth that you need to extract, and you plan to leave a piece to keep some of the periodontal ligament, that will keep some of the bone, that will keep some of the gum, basically keeping that structure, that architecture on implants and on Pontic sites, both, right?
Lots of Pontic sites.
And as you mentioned, you took this to the next level, but this concept started somewhere. Can you explain to us where this type of concept started? Who are the people who started to research and develop the initial techniques? And what is the evolution? What did you add to the technique that makes it better today compared to where it started?
Cool. Basically, I mean, ridge preservation using a root is such an old technique. It's older. It's 1965 was when it was first developed. So it's a very age-old tradition where we used to do it. We used to cut off roots, sink it under the gum so that the ridge was maintained for a denture. So that was the key to it. And then I think in 2008, Maurice then reintroduced it because it was in and out. It didn't really gain much traction. And then Maurice introduced it with a brilliant article, I think in 2007 or 2008. Him and Ishikawa, David Garber, Henry, etc., where they used it next to an implant site where they managed in a Pontic site under a bridge to maintain the papilla, to maintain the ridge integrity. And the case that they published was just sensational. It was out of the top drawer.
These two initial examples, you're talking about keeping the whole root, right?
The whole root.
Just cutting the crown off at a specific level and then closing the gum on top of it.
Yes, which is key. So you're basically cutting off the root, whether it's a root canal treated tooth with no pathology, that's key, has to have no pathology, or even if it's a vital tooth, which works even better if you have a vital tooth, and that is the best way. It's simple, it's easy. You cut it off, you sink it under the gum. You just have to have some soft tissue skills, which are important to be able to sink it properly and not have the complications of the flap opening. And that thing just maintains, and it sits there. And often what happens, we've got histology, we've got clinical radiography where you can actually see the bone growing over. So in the vital one, you get a dentine bridge forming, you get bone growing over the top if you've prepared the root properly, and it fuses and stays in position, because people have this concept, well, if you put it there, it's going to over erupt, it's going to do this, it's going to do that. But it doesn't, because the Pontic holds it in place, and the soft tissue holds it in place. And it keeps the ridge absolutely perfect. You don't lose anything.
Yeah. So basically, this is something that nowadays is common sense, and people should leverage this basically for bigger bridges, over teeth or over implants, to preserve the Pontic sites in between the abutments, right? Now, there was a moment where then professionals, they took that to the next level, right? Where you're talking about the extraction site and how to preserve that.
That's right. So in 2010, Marcus Hertzler and Otto Zur published a paper, Proof of Concept. It was an animal study where, I don't know where they got the idea from, but it was absolutely brilliant. They were trying they're trying everything to try and ameliorate the collapse of the ridge. And they came up with this concept of socket shield, where you kind of you leave a shield behind on the buckle. That buckle, you're taking everything else that's behind, and then you're sinking an implant behind. And they showed histology, which really, that animal study histology, which really showed that the buccal plate, the bundle bone, however thick or how thin it was, stayed behind. It did not collapse at all. It did not move. Your soft tissue remained stable. And then they showed internally, where the implant connected against the shield, that you got bone formation. And that bone formation then created ankylosis to the root, which kept the root in place and locked the root in place. And that was a revolution.
So if you're slicing a case like this sagittally, you have the patient's gingiva, you have the patient's bone, then you have the periodontal ligament, then you have this cementum, the dentin, the root dentin, then you have bone again, and then you have the implant. Is that correct?
Correct.
And because of that, that little piece of tooth is keeping the whole architecture on the buccal, creating a more aesthetic outcome for the implant.
I think we have to also say that the buccal is key, but what's even takes us to another level is that we extend it slightly interproximally, and it
That's what I was going to ask. Yeah.
maintains the bone interproximally. So we've got cases, there's publications from Joey Chen, from Joseph Kahn's group, where they show phenomenal stability, central lateral, which is our most difficult thing. Two implants
Yes.
next to each other, fairly close, not so close, not, you don't get much space for a papilla growth there, but maintains the bone. And I think they showed that your bone loss interproximally was around 0.4 millimeters. Your papilla loss height on average was 0.41 millimeters, which is negligible and or not even kind of discerning by the eye. And that's where this technique really explodes everything, because everyone has a lot of different techniques and they work. They work under certain conditions, but where this one takes everything to the next level. And I think that's what makes it so exciting.
So you're now kind of not only leaving the buckle, but allowing some of the interproximal of the root to stay there. Is it a situation where you just keep the interproximal part in?
There are techniques where you can keep the proximal part, and Joseph Kahn published a technique called the interproximal shield, and I think, if I'm correct, and I stand corrected by Joe, but I mean, we've lectured together a number of times, and he says that's his go-to, that's what he would like to keep it as, to do the interproximal shield. Works perfectly, a little bit more tricky, and you're also sectioning buccopalatally, which means there's a risk of damaging that buccal plate. So I would prefer not to do that, but I've done cases like that where you don't have buccal plate and you need to keep the interproximal papilla, and you can do that. So it's very versatile because it's very biological.
So before you explain how you started to use it and evolve on top of it, I think the main point here for a general practitioner or somebody that is, even a GP that is collaborating with their periodontist and see the opportunity, and know an anterior aesthetic case, demanding patient, or a young patient, somebody that you really want to make the aesthetic right? You don't want to mutilate the person and not have the ability to smile again because the gum is just not there. And we know that it can disappear in a blink of an eye. The main thing after all these years, you said 2005, 7 with Maurice publishing the root submergence, and then Otto Suhr and Hertzler publishing the socket shield, and all the variations that you explained. The main conclusion is that we already have enough data to say that leaving a piece of the root properly works.
Without a doubt. I think, we have a number of randomized controlled trials. We've got systematic reviews with meta-analysis. We've got prospective studies, retrospective studies. Everything's there. You know what I mean? It's all done. It's all there. But we still, funny enough, it still has a lot of pushback. It's a very
that's my point.
mindset.
My next question was exactly that. Do you think people are leveraging this enough?
I don't think so yet, but I think, the crazy thing is, I mean, I started this nearly 12, 13 years ago, and then it was really tricky. Nowadays, you still have a lot of the old guard who are very much, no, there's not enough data, this very technically challenging, so difficult, possible complications and this and that. But the key fact is, because it works even when people don't do it 100% the way I'm doing it or the way it's doing, because it's biological, it's growing organically. It has no company that pushes it. No one makes money out of it, which is always a difficult thing, because if you make money out of it, companies push it, it grows like crazy. You make an industry.
There was a product involved, right? If there was a product involved, do the magic, it would be exploding.
It's exploding. But the crazy thing is that it's every conference you go to, and I think you will attest to that. Every conference you go through, it's now there. There's either a full lecture on it, or somebody's lecturing and they talk about it. Oh, and this is a socket shield case or a root submergence case that I did. It's out there and it's growing, because it works biologically and because it's free.
Yeah. So do you think that every time a dentist sees a situation where they need to do an extraction and place an implant, they should consider partial extraction therapy in every case
Without a
where they're
doubt.
extracting.
Without a doubt.
At least
Look,
consider, at least
at least
explore.
consider it. It might not be the right case, and you need to understand the protocols where you can use it and where you can't use it. But your first thought should not be, how can I extract this and place synthetic bone and a soft tissue graft? Your first thought should be, how can I keep, is there a possibility for me to keep all or some of that root to maintain the ridge the best way that I can?
That's the message that I think it's a paradigm shift and a disruptive message that even for me, even today, I saw you lecturing. I have to be honest, I saw you lecturing so many times. I know this is a serious topic, and only now asking this question to you is that I'm realizing that every time you extract a tooth, you should at least consider this possibility.
Absolutely.
Even myself. Yesterday, I was not considering that. And today, I realize that if it may bring benefits, it makes no sense to explore. So
100%.
based on that, how do you do it? How did you take this to the next level? What is the evolution of this protocol? I know that one of your goals is to make it more user-friendly, right? More people can do it.
Yeah. Well, I think that was the key. When Marcus and Otto published the paper, there was very little data as to how do you do it, what do you do. And there was a little bit of stuff, and as we, when you look at your own cases and you start photographing CBCTs post-op and you look at them 5 years, 6 years, and you start to see little mistakes, and then we've published one of the biggest cohorts, 128 cases. Mostly were mine, 127 were mine, one was Maurice's. And when you start to look back at your cases and you see your mistakes, then you start to realize where your faults lie, and you start to realize where people are having problems. And then again, when you teach things and people start asking questions, you start to unbundle and you start to dissect the procedure into very small parts, and you basically deconstruct a procedure. And I think the more you deconstruct and the more you understand how to deconstruct, the better the teacher you are. And the key factor is that once we started to deconstruct it and find where the problems were, then we started to look at techniques that would make it easier. And it's like a lot of times you're doing something in a hands-on, and then suddenly it's like, well, this doesn't make sense. Let me try this. Wow, that works much better. Now I've solved that problem, and I've solved that problem. It's only taken 10, 15 years, but hey, we're a bit slow, but we're getting there. slowly but surely.
Look, we know teaching is the best. Trying to teach is the best way to learn, right? So as you had the courage to say, I'm going to try to teach this, I'm sure that you started to have all kinds of ideas to make the protocol even better, right? And
Absolutely.
today, is something that, do you think that is something that only very skilled periodontists, implant experts should do, or, general practitioners that are placing implants could do that? What is the level of skills that somebody needs to have and experience with implants?
I have to be responsible here, not jump in and say everyone should do it, because it's not the case. If you don't have the hand skill, if you don't have the ability to manage complications, if you don't have, and that goes across the board for anything in dentistry, the same applies to socket shields. Is it technically challenging? Yes, it is. But I mean, anything is technically challenging. If you're not used to removing a wisdom tooth, your first 50 wisdom teeth are going to be a challenge, and then suddenly you start to understand the physics, the lever action, the way things work, where to take away bone, etc., and it becomes an easier procedure. So there's no doubt, anyone who places implants theoretically could do it. Should they just pick up a drill and do it? No, I think that's crazy. To read an article and to think that once I've read this, I'm now knowledgeable. That's crazy. I don't think anybody does that unless you are super skilled. You've got all of the techniques and the technologies behind you, and you can read something and you can follow the idea clearly, that you can put it into practice clearly. But if you're not, and a lot of people are not like that, then it's important that you take courses. It's important, and there's so many around the world. It's not, you don't have to come to South Africa to do a course. There are so many in the States, in Europe, and all around the world people are teaching. And I just want to say one thing. I have to also not it's important that I have a massive group of people that I work with, from India to America to Brazil to Spain to just all around the world, and it's kind of a combined it's a combined brains trust that thought of a lot of these things. It's not just me. It's a group effort, and I think, I mean, we speak about asynchronous communication. We think about the many brains in interdisciplinary treatment planning and things like that. And this is really also part of it. So it has to go out to everybody. It's not just me.
Of course, of course. No, you work with a great team, all your publications and research team, etc. Going back to the question, who should do it? Do you think that a general practitioner, a GP, that is placing its own implants pretty well, is it worth for this person to get the training to do this? Is something that you would do if you were a GP?
There's not a debate. I think, the rise of the super GP, as you know, is here. Are specialties going to last? One doesn't know. But the key fact is, anyone who has the hand skill to place implants well, this is a technique that really, it's very forgiving. And as much as people say it's very technique sensitive, yes, it is. It's still very forgiving because it's very biological. So people might not do it 100% the way they should, and I mean, it might be a little bit wrong in this way or
Connective
that way.
tissue graft. If you compare to the complexity of doing a connective tissue graft on an aesthetic zone or a crown lengthening, anterior crown lengthening, how would you rank in terms of complexity of the procedure? More or less.
Personally, I think it's easier. I
Yeah,
think it's easier. I
that's
think
what I.
everybody drills a tooth. Every single dentist knows what it feels like to drill a tooth. They know what it feels like when they're cutting through a tooth. They know what it feels like when they go through the tooth and into the bone. There's a haptic feedback
Bubble
that we
sensor.
have in our
Yeah.
hands, and it's muscle memory in the brain. Soft tissue is a massive skill because you have to now harvest. You've got a second site surgery. The harvesting on its own is very difficult and challenging for people to get right. Then to manage that, it's so finicky and so precise.
Yeah.
I
Delicate.
I
Yeah.
think this is a simpler technique for most people to take through.
Got it. So it's basically the conclusion is that it works. You should take that. You should explore this possibility every time you're gonna do an extraction. And if you do, implants in general, even if you're not a specialist, if you're good placing implants,
Absolutely.
this is easier than doing other things that you're already doing.
100%. And the techniques that we have today, with the guided surgeries and things like that we're utilizing today, they've made it even simpler. And a lot of the complications that we had, we've eliminated. We've published them. They're well documented now because of the way that we've changed the technique and the way things have kind of gradually grown. So it's without a doubt, it's something that should be on everyone's mind. It should be front and center.
And have you ever thought about developing guides to guide the trimming of the remaining root?
There've been a lot, and obviously, luckily, when you do publish, you tend to get a lot of the review papers and things like that to look over. And there've been a lot of people that have tried. The only thing that we've got right guided at this point in time is the actual hitting of the apex with guided surgery, either static guides or dynamic guides. The actual separation of the root, which can be a challenging part, or probably the most challenging part of it, because of angulation changes and things like that, and being able to really think three-dimensionally.
Yeah.
That part hasn't been, we haven't got the ability with that.
It's not like a straight cut, right?
It's
not
not
like
a
a
straight
straight
cut. You're
cut.
kind of cutting a circle. You're cutting a smile. It's a smile.
It's the concavity. There's a different
Yes.
concavity in it, and it
Yes.
curves as you go
Yes.
down. So
But your drill does create that concavity to start. You just then have a small part to section on the sides, but getting that angulation right, buccopalatally and mesiodistally, that's the tricky part. And people have developed
prepping a
guides.
crown. Yeah.
Say again?
Prepping a crown is probably more
Yes.
difficult.
Without a doubt. I mean, I mean, when you prepping a shield, you've got much more leeway for error than you do when you're prepping a crown. If I now prep through the papilla, it's a disaster. You know what I mean? There's no coming back and kind of gluing back the tooth. If I prep a little bit too much of the shield or I go a little bit too deep into the bone heals.
Uh-huh,
The
uh-huh.
shield will still maintain the buccal portion of the root. So there's a lot of leeway, and I think it's
Mhm,
a
mhm.
it's far simpler than I think people think or believe. And I think the new technologies we have made it that way.
Mhm.
I
Yeah.
hope it made it understandable for even. I think that's the key
100%.
factor. If somebody who doesn't do dentistry can understand it, then you know that you're putting your point across properly.
That's why Kirk is here, because if he can understand,
Yeah, I had a million questions, but I got to stay in my lane too. Like misunderstandings, predicting the future. And when you're teaching something that's new and revolutionary, you're always going to face opposition, a little bit of naysaying. And
Absolutely.
but
I always tell people well-behaved
yeah.
people never make history. You know what I mean? You can't,
That's a good one.
you can't.
Howie is definitely not well behaved.
Yeah.
That's not one of his problems.
You know, the key for me is the bullshit that's out there. There's so much bullshit and
Yeah.
there's so many bullshit techniques that I've tried and I've failed at so many times.
Right.
And people claim because there's, you get paid an honorarium, you get paid, it's an honor to stand on a stage, but there's so much bullshit out there. And I failed so many times in my life that it became frustrating. And for the first time now, with this technique, the failure rate of long term, I'm not talking about the little smart 6 months, 1 year. I'm talking about 7 years, 10 years, 12 years, where my cases look as lip smacking as they did the day I placed them. Why it's worthwhile jumping into them.
Well, my biggest question, we can add this in, is like how you're facing opposition with this revolutionary tech. What do most people get wrong about partial extraction therapy? Like, what's the number one thing people get wrong about it?
You mean when they're actually doing the procedure or as a concept?
No, the whole concept. The
Yeah.
whole concept. They naturally say, "Well, that would mean this," and you're like, "That's not exactly true." You know?
Yeah. Well, I think most people feel that it's the paradigm shift of leaving a piece of tooth behind in the body is so conceptually foreign that their belief system is that you're going to have complications, short term, medium term, and long term, which we've published. It just doesn't happen, and we've eliminated those complications by doing things in a different way, by shaping it certain ways, by drilling in certain ways, etc. We've eliminated that. The second thing is the technique sensitivity, that they feel that no, this is too challenging. I can do it far better if I just take this out, put an implant in, put bone, put a piece of soft tissue, which also works under most circumstances. But I think that is more challenging in a certain way. And also, you don't get as good a result. You don't get the bone stability between implants. You don't get all of those factors. So it makes no sense. But the key for me, I suppose, the thing that I always want to say to people, and I never do it, one never wants to be rude, but the thing you want to say is, how many have you done? If you've done some and you're finding it challenging, okay, then let's have a conversation. But if you've not done any and you're telling me it's difficult to do and you have a lot of complications, that's a different story. But it's not what we find. I find traveling around the world, even the novices come up to me and say, Howard, I've done 5 socket shields. My first question is, well, what do they look like? And without fail, it's like they're the best immediate implants I've ever done in my life. They look phenomenal. And that's why it's growing. That's why it might take a couple of years, but eventually the tide will turn. It's like turning a tanker in a harbor. Takes time. And eventually it will become obvious, the same way as everything else in life that's we challenge. Then it becomes obvious, and then everyone becomes an expert.
Yeah.
Certainly in my hands, a lot simpler.
So partial extraction therapy. I know you're always kind and humble to say people can go everywhere to learn, but if I want to learn from you, how do I find you? What type of programs you give? What is the next one?
Well, we give a couple of courses a year in we have an international one, because if people are flying to South Africa, which and Cape Town, which, as you know, is it's not a nice place to visit. There's got this mountain, the sea, this wine. It's really it's tough. it's,
Very tough. Yeah, it's
it's a
a
tough
rough.
place.
Yeah, very boring. Yeah.
It's very boring. And then, of course, we also have all those wild animals that are very scary to see. You know, the lions, the leopards, and stuff like that. So we try and make things as easy as possible, so that when international people fly in, there's kind of a
Amazing experience. Yeah.
there's an experience to it, which I learned, funny enough, from the Aganinis. Create the experience, and they will come. So,
Yeah.
we have it a couple of times a year. It's available on our academy's website. And then obviously we teach it around the world as well. I mean, there are many places where we do hands-on courses. We did one in Dubai now. We were at the IRIS conference in Dubai together. We did a full day on partial extraction therapy. Look out! It's on our Instagram page. It's on our academy Instagram page. It's all over the place where you can
What is the name of your academy?
the Implant and Aesthetic Academy.
Implant and Aesthetic Academy. What is the website?
It's www.implantacademy.co.za.
And your Instagram?
Instagram is, I think it's Implant Academy.
Yeah, I think that's the one.
I think
That's the one.
These are things I don't
That's
know.
how people. Fantastic. So
Awesome.
everybody listening, keep an eye on Howie's programs and get partial extraction therapy into your toolbox. You just heard it works. It is not that complicated. You can learn it, and you should consider it in absolutely every case you're doing an extraction and planning a pontic or an implant on the site. So if it's socket shield or pontic shield, everything is under the umbrella of partial extraction therapy. It makes total sense, conceptually speaking, and physiologically, biologically, after 20 years, is proven that it works. So, Howie, people know how to find you, and I want to thank you so much. I think it was straight to the point. We have 30 minutes, and we were able to share the message precisely. Thank you so much, and I hope to see you in person in one of our next congresses.
Thank you, Howie.
Thank you so much. Thank you for having me, Kirk. Thank you. It's been a pleasure. And look out. It's an exciting thing. It's the best thing that I've ever experienced in dentistry, in implantology. Nothing compares to my results with PET. Nothing. And I think that says a lot.
That's the name. PET is the name. That's it.
Cool.
All right. You
Thanks.
good?
Guys.
All good.
Yeah. Great job, Howie. That was awesome. Thank you.